Okay, so the hip in lateral, especially if you're after the soft tissues and you're going to have a still muscle moving bone, is very advantageous. Usually if you're working from behind the patient, you get more. I want to do this in supine because there's way more opportunities for leverage in supine that can look very different, but the aim ends up being more or less the same. So you can use straight legs, you can use bent legs. I would never suggest using two legs because it's just heavy. No matter how big or small the person is, it's extra work for you. So if I'm thinking about hip flexor-ish tissue or kind of somewhat inferior to ASIS, I can get some tissue there. So I can literally just lean on it, right? But the problem is if I lean too hard, I'll just kind of roll the pelvis. And then at a certain point, I'm producing a bunch of pressure. So if I do that, that's okay, right?
Yeah.
If I do that
Sucks.
right? So I really need to get deep in the tissue. I'm like, you're not paying attention with your eyes to whether or not the other side is moving. And because you squish at a certain speed, you will more or less overwhelm all of the different frequencies of palpation in the heel of your hand, the 2-point discrimination, and you also feel your hand squish, and then it's awesome because look how deep I am. The speed at which you apply makes a difference. Now, if I go like this, and I go like this, now I can work that anterior tissue, which is sort of hard in lateral. You can have superior to inferior force on the lateral side of this, right? Oh, sorry. Oh, there you go. So all of that is just as I move the limb a little bit, her tissue activated. So I'm like, okay, I don't want to do that. So this is fine. This is manageable. If I bring it up here, you can feel it gets softer, but I'm not on it the same way, right? Okay, now a bent leg, I can work on this in a similar fashion. So now it's just a little bit more shortened. That anterior tissue is a little bit shortened, but I have less access to that tissue because the thigh is closer to the abdomen. I have to adjust my hand. I can come off of it, but now I'm further away. So if I'm here, this doesn't look hard on me, right? If I'm here, I'm loading in an awkward way. So I can work this. This is okay. I can do it. It's just that. The pulling up from here, look, right? It's not that good, right? Because it can be so forceful because I have a straight arm, I can literally just lift the whole pelvis more or less and rock it. I am no longer working on what I'm wanting to work on, right? So I'm going to come to this side, so hopefully you can see some of this, but you'll want to be over here. Okay, so under the circumstances, now I can do that, right? Now, this is no good, right? So now I need to essentially make sure that the pelvis is stable and the leg is stable, or the thigh. Now I'm checking that tissue. At least in this position, you'd agree here on the posterior side, going posterior to anterior. Now for leverage, I could do something like this. So this is working those soft tissues perpendicular to fiber direction in a relative sense. Obviously the tissues that are further posterior, I'm just not going to get to. Not in a meaningful way. Now, although in a relative sense, flexing the hip will lengthen this a little bit, it's not going to be bad. It will shorten this. So when you shorten the tissues, they get a little bit easier to work on, a little bit easier to mobilize, right? So now this automatically changes what my hand can do based on available space. So I'm further away because I want you to be able to see this to some degree. So what it would look like now is I'm going to use the thumb on the top, but I'm going to not try to use the thumb pad. I'm going to try to use the thumb, the whole thing, right? So down, up. Now in this case, actually, it's still that. It's still on the back. And then my leverage is simply here. So actually, when I bring the leg this way, it probably bothers you less. When I take it this way, it probably gets tight and gives you a little bit of sensation, right? It's not big, but it can be as small as this. And now this is working that soft tissue. And just right there, nice and small. And I'm consistently trying to avoid those patient activations. I'm trying to make sure that the tissue doesn't jump. Now when I bring it here, you don't feel much. I can keep going. Right? So that's a small way within the method for me to know that I've made some difference, because I can bring her all the way out here, that was different. That was the front of your hip, right?
Yeah.
Yeah. Because nothing popped into my hand, so there was some resistance. I'm like, that's not where I'm palpating. It's not where I'm paying attention. Right there. Now, in the same position, I let the hold off. I keep my hand in about the same place. Push down. That feels different even there.
Yeah.
Different. Not perfect. And there's some degree to which I'm just going to run into bone a little bit more quickly. You can do this too, right? So when you need to be more on the front side, this is an option. But if I need to check both front and back based on hand position and leverage, the thumb on top and a thumb bar crossing a bunch of tissue as opposed to a thumb back, because that's not nice. No. So the broader the contact, the more comfortable it is for the patient, the more information you get. So broad contact for multi-point discrimination, it ends up being useful. Those are approaches that you have available in supine, lateral, and prone. Not terribly hard to figure out. Fair enough? Sweet.